Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on acute exacerbation of chronic obstructive pulmonary disease or COPD. So the etiology of this is pretty much the same as the etiology of having COPD. And that is to say that the biggest risk factor is going to be smoking, which is the cause in about 80% of cases. The rare condition of alpha-1 antitrypsin deficiency also exists. However, most common trigger for a COPD flare-up is going to be infection, and non-infective exacerbations do also occur. And the big factor that you need to take into account in those circumstances is adherence to medication. Signs and symptoms of COPD exacerbation is classic, and it's something that probably most of you taking MRCP have already encountered. These include worsening breathlessness, wheeze, exertional dyspnea, productive cough different to the usual, that is either in the amount or the color of the sputum, pyrexia. They could potentially present with signs of sepsis, cyanosis, respiratory distress, weight loss. In advanced COPD, you could get signs of involvement of right-sided heart failure, including cor pulmonale, raised JVP, right ventricular heave, loud P2, tricuspid regurgitation, peripheral edema, hepatomegaly, a flapping tremor of CO2 retention, and finally pursed-lipped breathing. Investigation of exacerbation of COPD will depend on what you think the cause is. However, as like anything else in medicine, history and examinations are key. You would normally be checking observation at the bedside and correct those observations as appropriate. So for instance, if the patient needs oxygen, you would supply them with oxygen. Then you would want to take some blood tests, check for inflammatory markers and lactate. You would do a blood culture, sputum culture to try to help you target your treatment. Then it's really important to have an arterial blood gas to check for CO2 retention and compare it to the previous readings. And having CO2 retention obviously is something that is quite classic of COPD. Patients with COPD can be very well, but be in compensated type 2 respiratory failure. The problem with flare-up is that decompensation, because of the added stress of having, for instance, a bacterial infection, will turn into a decompensated type 2 failure, and therefore the patient will end up in acidosis. You would ask for a chest x-ray to look for any bacterial infection or superadded pneumonia. And as any other medical patient that will get admitted to hospital, the patient will need an ECG. And that is mostly to check for any evidence of arrhythmia or any evidence of right-sided heart failure. The DECAF score is something that's frequently used in the UK to try and risk stratify the severity of COPD flare-ups. These include dyspnea, and that is on the extended MRC dyspnea scale, blood eosinophilia, consolidation on chest x-ray, acidemia, and any evidence of atrial fibrillation on the ECG or any history of paroxysmal AF. The management of exacerbation of COPD really is bread and butter of acute medical take, and that is having back-to-back nebulizers with salbutamol and ipratropium, oral corticosteroids at the dose of usually 30 milligram per day, repeating of the ABG after having the optimal medical treatment, which is the back-to-back nebulizers and the steroid. And if the patient is still not improving despite that, then there need to be a discussion and consideration for non-invasive ventilation. If you want a recap of non-invasive ventilation, please watch our previous video that was discussed here. Prescription of antibiotic very frequently is done, especially if the patient has raised infection markers or any evidence of sepsis, or you're suspecting as a clinician a superadded bacterial infection. Providing patient with oxygen and titrate that oxygen according to patient saturation. And finally, especially if there is evidence of right-sided heart failure, giving them diuretics in the form of furosemide, normally to try to offload their chest would be the usual practice. Let's do some questions now. A 70-year-old lady is brought by ambulance to the emergency department with a 1-week history of cough accompanied by production of green sputum. She has a background of COPD. Which of the following statement is incorrect? A. She should receive an annual influenza vaccine and pneumococcal vaccination every 5 years. B. Smoking cessation and pulmonary rehabilitation are key to management. C. Her chest X-ray is likely to show hyperinflation. D. She should be immediately started on therapy with inhaled salbutamol and ipratropium and steroids. E. She should be considered for CPAP if her ABG is not improving after 1 hour despite optimal medical therapy. And if you recall from our previous video on the management of COPD in long term, you would remember that the options A is correct. And these patients will need to have annual influenza and 5-year pneumococcal vaccines. As discussed earlier, about 80% of cases with COPD is caused because of smoking, and any time the patient can stop smoking is going to increase their chances of survival. Therefore, smoking and engagement with pulmonary rehabilitation is strongly recommended. C is a chest X-ray, which very frequently shows hyperinflation or hyperexpansion, which is a radiological sign in patients with COPD. And D is describing the immediate management that I'm pretty sure all of you would be familiar with, which is back-to-back nebulizers and steroids. And E, it is correct, however, if it was mentioned for BiPAP instead of CPAP. If you want a recap of the differences between BiPAP and CPAP, please click here. However, CPAP is not going to be the choice of treatment for patients with COPD. Remember, patients with COPD have problem with excreting carbon dioxide, therefore providing them with more and more diaphragmatic splinting, and more oxygen is not going to help with that. They would need oxygenation, however, they would also need help with excreting that carbon dioxide, which CPAP is not going to offer, and the correct mode of ventilation will be bimodal or BiPAP. Therefore, option E is incorrect. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.